So good morning, everyone. This is Adrienne McDonald. It is my distinct pleasure to introduce our speaker this morning, Dr. Jenna Holmen. Jenna and I have actually known each other since intern year. We trained together. And after a few years of sowing seeds, I've convinced her to come home to Santa Barbara to be our new pediatric infectious disease specialist starting this summer. So we're very, very excited to have her with us this morning. Just as a bit of background, Dr. Holmen went to Dartmouth for her undergrad, followed by Boston University for a master's in science, and then finally Eastern Virginia Medical College for medical school. She then returned home to California for pediatric training, as well as her pediatric infectious disease specialist, both at UCSF Benioff Children's Hospital, Oakland. And during that time, she also obtained a master's of public health through Berkeley, working with the very esteemed Art Reingold. So she is faculty there now at Children's Hospital Oakland. And again, we are very, very excited that she will be joining us. She has been a huge support and resource to me, as well as the rest of the hospitalists over the past couple of years. We all appreciate having our own pocket PEDS ID specialist, and very happy to make it official. She's here with us this morning to speak with us about pediatric joint and bone infections. And without any further embarrassment, Dr. Holmen, please take it away. We're very excited.
Thank you so much, Adrienne. I can't tell you how excited I am to come join everybody at Cottage. Come home finally. But I am delighted to get to talk to you today. So today I'm going to talk about pediatric bone and joint infections. And I have nothing to disclose. I didn't make a disclosure slide, I'm afraid. All right, so pediatric bone and joint infections are different than adult bone and joint infections for many reasons, but one big reason is the mechanism of spread. Pediatric infections are far and away most commonly acquired via the hematogenous route. There is a small subset that is acquired by direct inoculation. This is usually in the setting of trauma. And then others that we see that are due to contiguous spread, usually from an adjacent soft tissue infection or synovial tissue infection. So why hematologic spread in children? Well, because children have growing bones. And so because they're growing, these bones have a really robust vasculature. And essentially what happens is bacteria will enter the bone through the nutrient artery, which then travels to the metaphysis, where there are these metaphyseal capillary loops. And if we all remember from back in medical school, capillaries are designed to have sluggish blood flow so that there can be exchange of nutrients. However, this sluggish blood flow also allows for bacterial deposition, which is further aided by the fact that capillaries are very thin-walled and they lack a lining of phagocytic cells the way other blood vessels might have. So this makes an excellent way for bacteria to anchor to areas of exposed cartilage, especially in the metaphysis of the bones, growing bones. And there they can form these large bacterial colonies that then produce a glycocalyx, which will obstruct capillary lumens and impair phagocytosis and even sometimes antibiotic penetration. So this is just sort of a graphic of the process. Here's the nutrient vessel, and this is the capillary loop in the metaphysis where the bacteria can really spread and enter. And important in this graphic, you can also see how close this is to the growth plate. So something we always worry about in this setting of pediatric osteomyelitis. This is a gross specimen of a 6-month-old. This is their humerus. This poor child had pretty severe osteomyelitis, and you can see what should be this red, pink, healthy bone tissue was completely destroyed here and here by the infection. So a little bit about epidemiology. The pediatric osteomyelitis, the incidence is somewhere between 1.2 to 13 cases per 100,000 children per year. So not super common, but not the rarest disease we see either. It is actually more common in low-income countries, and there's a male to female predominance of 2 to 1. In general, patients will present within 5 days of symptom onset, and 50% of the cases occur in children less than 5. The long bones are the bones that are most commonly affected, and the femurs having the highest incidence of infection, somewhere between 23 and 29%, followed closely by the tibia at 19 to 26% of cases, and then the humerus. But overall, there's so many small, short tubular bones that these do account for up to 25% of cases in total. A very small percentage, 1 to 2%, will have spondylodiscitis, and 5% of cases will present in multiple bones. In my experience, many of these are the more sicker kids that had more aggressive spread. And 35% will have a contiguous septic arthritis. So something to always keep in mind when a patient is presenting with osteomyelitis. This is a list of the most common pathogens by age in acute bone and joint infection. Infants, it tends to be similar pathogens to what we think about with neonatal sepsis, with the exception of Staph aureus, which is just the most common cause of osteomyelitis across all age groups. Staph aureus is really the key driver of osteomyelitis. But neonates, we also have to think about E. coli, gram-negatives, GBS. For the young child, less than 5, Kingella is actually a pretty big player that is increasingly recognized in terms of its importance. But group A strep also is a known common cause in young children and older children alike. And there are certain risk factors that might clue you in to think a little bit more about certain bugs. An upper respiratory infection may make you think about Kingella. Likewise, a patient with some GI symptoms or aphthous ulcers. Patients with wounds or varicella should definitely make you a little bit more nervous about group A strep. Buzzword from board, sickle cell disease and salmonella. I can't say that I've actually gotten to see that very much, even though we have a relatively robust sickle cell patient population in Oakland. But it's definitely something I always worry about when I have a sickle cell patient who has concern for osteo. Penetrating wounds through the sole of a shoe. Importantly, we're always taught to worry about Pseudomonas and anaerobes. Though it's important to note that if these patients present within 5 days of the injury, Staph aureus is still going to be much more likely than Pseudomonas. Pseudomonas tends to be more indolent, and patients with infection from that via this mechanism tend to present closer to around 2 weeks. And it tends to be a little bit less red and angry than that caused by Staph aureus. Of course, any patient who lives in a TB endemic area, we should worry about tuberculosis. And patients with CGD or other immunodeficiencies, we have to think about more unusual organisms, such as serratia, fungus, etc. The clinical presentation, fever is common, but not necessary. So 62% of patients, roughly, will present with fever. Refusal to walk is very common, especially remembering that the femur and the tibia were the most commonly involved bones. Obviously, a humeral osteo, they could walk just fine. You may have focal tenderness, plus or minus erythema, swelling, or warmth. Infants, it's always much trickier to make this diagnosis, and often the diagnosis is very delayed as a result. Though infants can present with pseudoparalysis, which is essentially failure to move a given extremity, which is secondary to pain. There's also something called pseudoparalysis of Perot, which is something we see in syphilis. Similarly, these babies will not move an affected limb due to pain, but that's due to metaphyseal erosion from the spirochete. Pelvic osteomyelitis is really hard to localize. These patients will have generalized pain in the area, but they really can't pinpoint where the pain is due to the way the nerve supply is in that area. This is a busy table from the European guidelines on pediatric bone and joint infections. But essentially it shows you different symptoms based on age group. And, babies can be very tricky. They can have fever, but often they don't, and they might just have irritability, poor feeding. If you're lucky, they'll have some clue on exam to help guide you, but not always. And then the older kids are the ones that are more likely to have more localizing symptoms, failure to walk, etc. This is a kid who had a pretty severe presentation. He had severe osteomyelitis of his humerus, and we'll look at his x-rays a little bit later. But you can see this one is not hard to miss. He has pretty pronounced erythema and swelling of the area, and I would bet money it was warm to the touch as well. This is a graphic just to help guide the diagnostic evaluation. So when you have a patient who is presenting with symptoms suggestive of osteomyelitis, of course, the first step is to get some baseline labs, and it's important to always get a plain radiograph. Although an X-ray is not the ideal imaging modality for osteomyelitis, it is important in the initial presentation to help rule out other entities. But labs that we generally like to get include a CBC, a CRP, ESR. Nowadays, I would also include a procalcitonin. Blood culture should always be drawn in these patients, and importantly, drawn before antibiotics. For the patient that has any abnormalities in this initial eval, then you want to move on to an MRI, the imaging modality of choice, plus or minus bone biopsy, which I'll talk a little bit more about later. For those patients where you have a high suspicion, but the lab abnormalities aren't present, you may or may not proceed directly with an MRI, or you might choose to observe and repeat labs, sort of depending on the clinical scenario. And this is just a nice little chart looking at the sensitivity and specificity of MRI versus other imaging modalities in the diagnosis of osteomyelitis. I'm disappointed this particular table didn't include x-rays, and I'm confused as to why they included ultrasound. I've never used ultrasound for osteomyelitis. But if we look specifically at MRI versus CT scan, because these are the two I've often seen used, an MRI has a sensitivity of 81% versus only 67% for a CT scan. So at least where I'm currently at, we'll get patients transferred from outside hospitals where they may only have had access to a CT. And if the CT doesn't show evidence of osteomyelitis, but we have a high clinical suspicion, we'll certainly always proceed with an MRI due to the higher sensitivity. MRI also likewise has higher specificity, 67% though, so not perfect by any stretch, but certainly better than 50% seen in a CT. And that patient I showed you a photo of before with the red angry humerus, this is a nice telling example of how x-rays appear in the setting of osteomyelitis. So this first x-ray here in the left, this is when the patient presented, and we could see on clinical exam, his presentation was quite severe. However, his osteomyelitis is up here, and you can see the bone still looks relatively healthy and intact on radiographs. I'm certain his MRI did not look this way. But even just 4 days later, you can start to see a whisper of irregularities in the bone. And then as we progress down, we can see how grossly abnormal this bone was, in fact, was due to the severity of his infection. In this last image here, this is 6 months almost after presentation. The bone is fully healed, but you can see it's still quite significantly under the remodeling process. And just to mention these little colored arrows, these are just different antibiotic courses the patient was on. So impressively, he finished his antimicrobials here at the end of July 21st. And this patient had full recovery, full healing, but this x-ray taken in September looks terrible. So the radiographs really significantly delay clinical resolution and improvement. So oftentimes the question comes up whether these patients need surgical debridement. And it really depends on the clinical scenario. So surgery is always necessary and indicated for septic arthritis. You really have to clear the bacteria out of that joint space. But it's not always indicated for osteomyelitis. So it's necessary for osteomyelitis in the setting of an associated abscess. And certainly often if there's bony destruction, you really need to debride out that dead bone. Otherwise it can be a nidus for the bacteria to hide out and propagate. Just in a couple years ago, actually just last year, the US finally put out their guidelines for pediatric osteomyelitis. And their guidelines actually pretty strong in recommending a biopsy just for the sake of obtaining a culture. Whereas European guidelines tend to be a little bit more lax in terms of that recommendation. I will say where I am currently, that's not commonly done. Given the risks of surgery, most surgeons don't want to proceed with biopsy if there's a chance to try medical therapy first and there's no abscess or other indication for surgery. So when you're choosing your antibiotics to start, your empiric therapy must always cover Staph aureus. Whenever you choose empiric therapy for an infection, the first thing you should think about are what organisms am I trying to treat and cover? And as I showed earlier, the organisms involved are always Staph aureus, Staph aureus, Staph aureus, and then other considerations based on age group and presentation. In terms of whether you should consider MRSA coverage, that's going to depend a lot on your local epidemiology. So that's where your antibiogram comes in to be really helpful. Certainly if the patient has a history of known MRSA colonization, that would prompt me to include MRSA coverage empirically. And for a patient who's presenting severely, that does increase the risk for MRSA, and it also makes the threshold for potentially not covering the correct bacteria is something you don't want to do. You want to start broader. And then of course, like I mentioned, you want to consider other potential organisms as based on the patient. One important comment about this, Kingella, like I mentioned, is increasingly common or recognized in bone infections in children less than 5. And Kingella, importantly, is not treated with clindamycin. So this age group, even if you have a high MRSA rate, it makes it a lot trickier to do empiric therapy because clindamycin will cover Staph aureus, but it won't cover Kingella. Keflex or Cefazolin will cover both, but obviously not MRSA. And this is just a nice graphic from the US IDSA guidelines about when you should consider empiric MRSA coverage or not. So if your local MRSA rate is less than 10 to 20%, then they suggest starting empiric therapy with non-MRSA coverage, such as cefazolin or oxacillin. However, if your local MRSA rate is greater than 10 to 20%, then they do recommend empiric MRSA coverage, which would generally be clindamycin, just remembering that Kingella caveat. Not every Staph aureus is susceptible to clindamycin, however, so you also then, if clinda is going to be your empiric, should take into account your local clindamycin resistance, right? And if that's greater than 10 to 20%, even if you have a high MRSA rate, you may choose empiric therapy with a non-MRSA covering agent, or you might use vancomycin. And then in the moderately to severely ill patient, you'll always want to include some MRSA coverage. And this is just a chart that shows the bone penetration by antibiotic. And I show this not to scare people, because those who have worked with me before or call me for consults will know that I love cefazolin for bone and joint infections. Not only does it cover MSSA and group A strep and Kingella, like all the common organisms we see, the oral equivalent Keflex, it tastes relatively good as far as oral antibiotics go. So kids tend to be more compliant. It seems much better side effect profile than Clinda or other options. However, this graphic looks scary because the bone penetration is quite low, but we counteract this by using really high doses such that we achieve adequate bone penetration for our needs. Clindamycin, this is one nice thing about it. It does have excellent bone and tissue penetration, likewise with linezolid. I also want to draw your attention to vancomycin, which has an incredible range here. And this is all about levels. I personally can't stand vancomycin because so often we fall behind in initial empiric therapy. And these are usually sick kids where we're using it because it's just so hard to reach adequate levels. So unlike Keflex, where I know ahead of time it has low bone penetration and I start with high doses, I can't do that with vancomycin because of the renal injury. So I risk starting with really poor efficacy if I can't get good levels in a reasonable time frame. And one thing that comes up a lot for debate, maybe just within the ID community, I don't know how much it affects you guys, but for really sick osteomyelitis cases, especially those due to PVL producing Staph aureus, which I'll talk more about, these kids can often have DVTs or thromboses and clots. Historically, we used to treat every infection with a clot or a thrombosis as we would an endovascular infection like endocarditis, which would mean prolonged IV therapy, and you could only use certain agents. However, more and more, but very gradually, the ID community is moving away from that mindset. And this is to show you how wishy-washy our community is. The IDSA guidelines that came out last year specifically wrote regarding the setting a DVT in the setting of osteomyelitis, the data are limited that specifically address antibiotic treatment regimens for acute hematogenous osteomyelitis with associated DVT. The presence of DVT is concerning, if not indicative, of endovascular infection. Use of bactericidal agents as per endocarditis for the entire treatment course for osteo with associated DVT is considered prudent by many. However, some experts have clinical experience with good outcomes when using Clinda. So essentially, there's no clear guidance in this setting. But I will say I have used Clinda or even oral therapy in these patients once they've clinically improved by all other metrics and they have had good outcomes. So the expected response to antibiotic therapy in uncomplicated osteomyelitis, these patients generally you should be able to expect fever resolution in 3 to 5 days. Though this can take longer in more disseminated infections or certain MRSA strains. In general, once you start effective therapy, the CRP should peak 2 to 4 days into therapy, and then slowly decline. And it should be less than 8 mg per deciliter, which is equivalent of 80 mg per liter, depending on the units of your hospital, by day 5 of therapy, and normal by days 9 to 12. If a patient is not responding to initial therapy, as you would expect, then important things to do are to reconsider your antibiotic choice, especially if you don't actually have cultures to help guide you. You want to evaluate for possible abscess or pyomyositis. So oftentimes we'll end up re-imaging these children because, as we know, abscesses can evolve over time. These are patients where I do worry about a possible DVT, and I might ultrasound an associated blood vessel. You should consider possible associated septic arthritis. Like I said, 35% of patients with osteomyelitis will have a contiguous septic arthritis. Always be on alert for new co-infections. C. diff, of course, are on antibiotics. More commonly, what we see in pediatrics are new viral infections, especially right now in respiratory season. And of course, you should also always, in the back of your mind, consider, could there be an alternative diagnosis? Was this culture negative osteo actually a tumor, an oncologic process, a rheumatologic process, etc.? For the patient that does respond appropriately, when can you transition to oral therapy? This is often a big question, and a lot of it is based on the patient and how on their clinical improvement. Certainly, you want resolution of fever and improvement in CRP. But importantly, you don't need to delay transition to oral therapy if there's a positive blood culture. When we have a positive blood culture in the setting of a known source and the patient's otherwise clinically improved and cleared their bacteremia, doesn't need to be treated with set number of days of IV therapy. You can transition to oral as soon as they've met all the other good clinical metrics. And they have shown this through systematic reviews, where in this particular one, an oral therapy group had a 4.6% treatment failure rate, 6.5% complication rate, whereas the IV therapy group actually had a slightly higher, though I think non-statistically significant treatment failure rate, but a statistically significant, much higher complication rate. So really, early transition to oral therapy in an improving patient is the way to go. And next question is, how long should you treat these patients? Well, uncomplicated osteomyelitis treatment courses can be as short as 3 weeks. There are scenarios where you'll need to treat longer, in the order of 4 to 6 weeks, sometimes even longer than that. But these are largely clinical scenarios just because they haven't been well studied. And these include scenarios such as resistant or unusual pathogens, PVL, which would include PVL producing MRSA strains, Salmonella, and other bugs. Newborns have a really much more robust vasculature, but as a result, you could look at it 2 ways. In one setting, the antibiotics should be able to get to the area much better with that blood supply, but then there's always the concern that there's greater spread of infection or they don't respond as appropriately. So many people still prefer to treat newborns, neonates for longer courses. The one group where I do regularly treat for longer are those who have complications or complex infections. These are the children in the ICU who are bacteremic for a week, who end up with like 8 surgical debridements. They tend to need longer courses of antibiotics. There is some theoretical concern that those with pelvic or spinal osteomyelitis need longer courses because the blood supply is even less robust in those areas. Certainly those who are septic, I would put in the complicated category, and they'll need longer courses. And immunocompromised may potentially likely need longer courses as well. But how did we get down to the 3 to 4 week duration? Because historically, osteomyelitis had been treated with 6 or more weeks of antibiotics. But that was based on very old data on patients that didn't have surgical debridement for complicated cases with abscesses. Well, there's this group of orthopedists in Finland who I greatly admire, but they did a randomized control trial to address the duration question for pediatric osteomyelitis. They only included uncomplicated cases, culture positive, and over 80% of the cases in their study were MSSA, and importantly, 0 cases in their study were MRSA. And they looked at durations of 20 days of therapy. And again, these were patients that had early transition to orals versus durations of 30 days or more. And the cohort was relatively evenly split between the 2 arms. And they followed these patients out for 12 months. And what they found is that the patients in the shorter duration, the 20 days of therapy, had non-inferior outcomes compared to those in 30 days. In fact, only 1 patient in either group had any complications, and that was a patient in the 30-day arm. And that complication was relatively mild. And this is just a graphic where they trended their CRP, their ESR, and their white count over a time. And you can see in this patient, both the short and long arm treatments had normalization of their CRP by day 9. And that normalization held through up to the year of follow-up. The ESR was slower to normalize. That took closer to 19 days, but remained low at 1 year of follow-up. So I want to talk a little bit about Staph aureus and Panton valentine leukocidin, the PVL toxin I mentioned a few times. So what this is an exotoxin secreted by somewhere between 30 to 78% of all Staph aureus strains, MSSA and MRSA alike, though it is more common in MRSA, accounting for 74 to 100% of MRSA strains versus MSSA, where somewhere between 9 and 46%. Interestingly, it's much more common in community-acquired Staph aureus as compared to hospital-acquired. And what it does is this PVL toxin will destroy leukocytes and cause tissue necrosis. So when you see those really severe cases of pediatric osteomyelitis, it's generally almost always due to PVL-producing Staph aureus. This exotoxin, I have a graphic on the next slide. Here's our lovely golden grape Staph aureus and this exotoxin. And what it does, it creates these pores in the neutrophil membrane, which lead to cytolysis, and then which activates a cytokine cascade, which will trigger platelet aggregation and thrombosis, and so it will cause DVTs. And it also allows for release of these defensin inhibitors, which will impair the clearance by the host. When they look at the prevalence of PVL producing Staph aureus by infection type, it's actually the most prevalent in skin and soft tissue infections. It's 10 times more prevalent in skin and soft tissue infections as compared to osteomyelitis. So that's a good thing that it's less common in osteomyelitis. However, it should be high on your concern level in the patient who has eczema or who had a known preceding skin infection prior to their bone and joint infection. And this is just really telling data. It's from a really small retrospective review, but I think it largely would be reproducible in bigger studies. But this essentially looked at the severity of a Staph aureus infection by the presence or absence of PVL production. And for infections caused by, and these are mostly osteo, osteo caused by PBL producing Staph aureus strains, 43% of them had severe sepsis versus 0 in the PBL negative cohort. Their CRPs were notably higher in the PBL producing cohort, and their length of stays were more than 3 times as long. 79 as compared to 6% of these patients had extension of their infection, and 71 versus 18% required surgical debridement. And in this small study, the average number of times these PBL producing strain patients needed surgical debridement was 3. So they had to go to the OR at least on an average of 3 times in 71% of the patients. And 86% of the patients with PBL producing strains had long-term complications versus 0 in the PBL negative group. So PBL makes a huge difference in a bone and joint infection. Unfortunately, it's something that you don't necessarily know ahead of time, but based on their presentation, you can generally theorize whether they're infected with this strain or not. And this is just a graphic looking at the different inflammatory markers in the PBL producing strains or not. The red bars are patients with osteomyelitis. The blue is non-osteo. So if we look specifically at the red bars here, the CRP in PBL producing strains is significantly higher than the PBL negative. The white counts are higher, the ANCs are higher, and the ESRs are higher. One interesting theoretical aside, because PBL toxin destroys leukocytes, there have been studies that have shown that the white count is actually lower in PBL producing strains, but the data seems quite mixed because I've seen it all over the place in different studies. But the data on the CRP and ESR are pretty consistent. One thing that we live in fear of in the ID world is chronic osteomyelitis, because it's really, really, really frustrating and hard to treat. Essentially what it is, when Staph aureus when the bone is digested by osteoblasts, Staph aureus can survive in this less metabolically phenotypically altered state for a prolonged time. It essentially goes into hibernation in this protected nidus of necrotic bone. Thankfully, it's not common. It occurs in less than 5% of cases, and more commonly in non-hematogenous cases of osteo. And the way it presents with alternating periods of quiescence and periods of pain or swelling, often over years. Radiographs, because it lasts so long, may show initial metaphyseal lucencies that over time become diaphyseal as the patient grows. And really the mainstay of treatment for this is surgical debridement. Because the bacteria lives in this nidus of necrotic bone, there's no good blood supply. So antibiotics can't get to that area. So you really need to surgically debride the area to remove the bacteria and the dead bone for efficacious therapy. A related version of chronic osteo is the Brodie's abscess, which is a chronic localized bone abscess, most commonly found on the distal tibia. These lesions are singular, they're near the metaphysis. These patients often present without fevers and with long-standing dull pain. Because the bacteria is not very metabolically active, the cultures are often negative. But in order to treat it, you need a combination of surgical debridement plus antibiotics. And then on the back of our minds with any patient who presents sort of along those lines is the entity of chronic recurrent multifocal osteomyelitis, chromo, as we commonly call it. And this is not an infection. This is an inflammatory disorder. It presents with recurrent episodes of pain and swelling over the affected areas. Patients often have fever. For all intents and purposes, The initial presentation especially will present like acute bacterial osteomyelitis. And the radiographs and imaging will be consistent with infectious osteomyelitis. Some important differences that can clue you into this being CRMO as opposed to acute bacterial osteomyelitis is that this tends to affect females in a much higher rate than males, 2 to 4 to 1 as compared to the male predominance of 2 to 1 with bacterial osteo. And this has a much higher average age of onset, closer to 10 years as compared to the 5 years we see with normal osteo. It can be associated with a number of other rheumatologic symptoms. And oftentimes presentation, it will affect just a singular bone. So you have a patient with fever, osteomyelitis on imaging, and elevated inflammatory markers. Oftentimes your first presentation gets treated like bacterial osteomyelitis. And then if they fail to respond to therapy, or because this is a self-resolving process and they resolve on their own, but present again later with a different bone affected, that's often when the diagnosis is made. Some things that can clue me into CRMO on initial presentation are the location of osteomyelitis. So the clavicle, especially the sternal end of the clavicle, is commonly affected in CRMO, where that's a very uncommon site in bacterial osteomyelitis. Likewise, the vertebrae and the smaller bones of the hands and feet are much more likely to be involved with CRMO than bacterial osteo. However, much like bacterial osteo, CRMO can also commonly present in the long bone metastases. The treatment really is NSAIDs, and as I said, many of these patients will self-resolve, but many will have a relapsing course for a mean duration of 6 years, and 20% can have a prolonged severe course. Just to quickly talk about pyogenic arthritis, septic arthritis, it overlaps considerably with osteomyelitis, so I'll be quick. But the incidence in children in developing countries for septic arthritis is 4 to 10 per 100,000 per year. The peak age is a little younger than osteomyelitis at 3 years old, and notably is also younger than the peak age of transient synovitis, which it can often mimic, which is 4 to 8 years old. The symptoms include fever, plus limp or refusal to bear weight, if this is in a lower extremity. The affected joint is generally warm, swollen, and red, and the presentation is very acute in onset. Importantly, whereas 35% of cases of osteomyelitis had associated septic arthritis, 68% of patients with septic arthritis will have an associated osteomyelitis. So it is frequently important in these patients to get an MRI, not across the board, but in many instances it may be warranted. The Croker criteria have been used to help diagnosis. These include fever, inability to bear weight, elevated white count, and inflammatory markers. And patients who have all 5 of these metrics will have a 60 to 99% positive predictive value of septic arthritis. Though it's very important to remember that the Croker criteria should not replace your clinical judgment. So if you have a strong clinical suspicion for septic arthritis, you should proceed with treatment and management for that. If we look at the joints involved, the knee is the most common, 41% of cases, followed by the hip and then the ankle. That's why we generally include failure to bear weight in the Croker criteria, because so commonly it's the lower limb that's involved, though less commonly you can get involvement of the elbow or the shoulder. When we look at the synovial fluid in these patients, it tends to have really high white counts, greater than 50,000, which is higher than we see with any other entity. Lyme arthritis can also get pretty high, but tends to run a little bit lower. This is the overall range here, and this is the average. TB arthritis likewise will have elevated white counts, but not quite to the same degrees. And then we look at the degree of left shift, really, it's almost all neutrophils when it's bacterial, or standard bacterial, I should say. Whereas we get a high neutrophil predominance in, say, Lyme or TB arthritis, but not to the same degree in general. And then, of course, viral arthritis, Reiter syndrome, rheumatoid arthritis will have lower white counts and lower PMNs. Again, when we look at organisms involved by age group, it's essentially equivalent to organisms by age group we see with septic arthritis. Neonates, you got to think about the neonatal bugs, but across all age groups, Staph aureus, Staph aureus, Staph aureus. Older kids, sexually active adolescents, you do need to be cognizant of gonorrhea. And treatment, again, very similar to osteomyelitis. Empiric treatment should target Staph aureus. The ultimate course will depend on culture, assuming your culture is positive, though it is, per the literature, positive in 90% of cases. Anecdotally, I don't think I've had it be, I've had quite the same luck. In general, you want to continue IV therapy until they're afebrile and the pain's improved, at which time you can transition to oral therapy to complete the course. And the total duration generally can be actually as short as 10 days, but anywhere between 10 days and 3 weeks. And like osteomyelitis, you may consider longer courses for MRSA or unusual pathogens just because they really haven't been part of the studies for the shorter courses. For those who have a slow or poor response to therapy. Neonates, again, just not part of the studies. And those with complicated disease, including DVT, sepsis, and immunocompromise. And those same orthopedists in Finland did a randomized control trial looking at durations of therapy for septic arthritis. And for their study, they looked at 10 days of therapy versus 30 days. And they found that 10 to 14 days of therapy was non-inferior. The patients in their study did an early transition to oral therapy and maintained good response. And the majority of patients in their study only needed initial surgical drainage. Like their study with osteomyelitis, the study again included no MRSA cases and was over 80% MSSA, and they were all uncomplicated. But here again, we see the graphics of CRP normalizing within 9 days, the ESR taking longer, and importantly here, it's still above 20 at 19 days out from the start of therapy, even though they stopped therapy at 10 days. But regardless of this, because the ESR always lags significantly, even in this light green bar, the short-term group where therapy was stopped, where antibiotics were stopped at 10 days, the ESR continued to come down. It became normal and stayed normal up to 1 year of follow-up. And so what are the potential complications of septic arthritis? Well, thankfully, most recover without any sequelae, 75 to 90%. The sequelae we worry about are joint stiffness, osteonecrosis, or abnormal bone growth. And those who are more likely to have complications are those who have a delay in diagnosis. Interestingly, within 8 hours after inoculation, joint damage can start, but most patients will have good outcomes if they're recognized and treated within 4 days. So you actually have a significant window despite the fact that joint damage starts so quickly. But I wouldn't take advantage of that window. I would still treat these patients emergently as soon as you can. And obviously those who have were started on the wrong therapy or incomplete therapy are more likely to have complications. Patients with sickle cell disease are always at increased risk for complications, as are neonates, patients with adjacent osteo. And as we showed, patients with PBL producing strains of Staph aureus just tend to have more severe infections and more complications in general. And this is just sort of a nice graph to help you look at the clinical scenario and think about what other clinical bugs to think about in addition to the usual bacterial causes. So obviously for a patient who's been hiking and had recent erythema migrans, usually 1 to 2 months before the joint infection, or if you were to move and practice in, say, New York, New England, where Lyme is more endemic, then you really need to think about Lyme arthritis. I will say anecdotally, we've been having a rise in cases in California. CDPH has been following this closely, and we've seen a huge uptick in Lyme arthritis, especially in patients in Marin up by me. So global warming is really changing the endemicity of Lyme. So we may be seeing more of that in our future. TB arthritis should be on your differential for any patient from an endemic area. Certainly viral arthritis based on the patient's symptoms and exposures. Fungal arthritis, we always worry about if the endemic mycoses, if they live in a geographic area to support that. And then also fungal non-endemic mycoses like Aspergillus we think about with the immunocompromised. And just to quickly touch on implicit bias, specifically in the setting of osteomyelitis, this is something medicine is increasingly starting to recognize the importance of. But sadly, the literature is lagging quite behind our recognition of bias. So there isn't a lot of data on bias in the setting of osteomyelitis. But this is one study that was done in adult patients that specifically looked at the frequency of surgical procedure, diabetes, and amputation by race for patients with musculoskeletal infections. And essentially what they found was that diabetes was the single largest independent predictor of amputation for these patients, which is no surprise, and really more of a thing in the adult world, which is the patient population of this study. But importantly in this study, when they looked at racial differences, in a multivariate model that corrected for diabetes, Black patients were still had an odds of almost 3 times that of other racial groups to receive an amputation. So clearly there is some racial bias going on in the amputation process for these patients. And there's one study I found in pediatrics looking at bias in the setting of pediatric bone and joint infections. And this was done in the TRICARE system, which is the military healthcare insurance. And what they did was a case control study of pediatric osteomyelitis patients with TRICARE, where they compared Black versus white race. They specifically chose just those 2 specific races because there was a huge other category that was very homogeneous, and I felt like it messed up the data. And then they also used military rank as a surrogate for socioeconomic status, presuming like higher level officers probably had more money, more status. And they use those 2 parameters to look at that 2 different outcomes, one being the rates of surgical intervention, and the other being sort of 90-day complications, which would include ED visits, readmissions, or complications of their infection. The patients were from a pretty large date range and a pretty large number, almost 3,000 patients in this case control study. And what they found in terms of differences between races, Black children were more likely to have a surgical intervention with an odds ratio of 1.78, but there was no difference in complications between the races, at least. And in terms of lower socioeconomic status, i.e. junior enlistees, the study found that a lower socioeconomic status was more likely to have 90-day ED visits with an odds ratio of 1.6, but there was no difference in readmissions or complications in this patient group, and there was no difference in the likelihood of surgery by SES. So the data was really mixed, but not glaringly bad, at least. So just a quick summary, the most common organism for pediatric joint infections is Staph aureus across all age groups, across all infection types. Other common organisms that you want to think about are group A strep and Kingella, but some of your risk stratification will depend on the patient age group. PVL producing strains, I hope I've instilled the fear of these into you, but Staph aureus that produce PVL can cause much more severe, complicated disease. When choosing empiric therapy for osteomyelitis, you should always provide coverage against Staph aureus, and whether or not you include MRSA coverage will depend on your local prevalence. Durations of treatment for osteomyelitis, for uncomplicated, generally as short as 3 to 4 weeks, and for pyogenic arthritis, 2 to 3. And with that, I just want to say thank you. It's been an absolute delight, and I'm happy to take any questions, though I know we are running out of time. I see one thing in chat. Yes, in terms of this question, do I recommend always obtaining contrast with MRI when looking for bone and joint infections? I do. If the patient can tolerate contrast, it's very helpful because the contrast really helps us to see, find the infection. It has much better visualization. So I do recommend that. I guess I should just leave this open. Oh, thank you. My pleasure.
Alrighty, so I don't see any questions. Thank you so much again for presenting for us today. It was a pleasure having you. For everyone, we will have our next PEDS Grand Rounds in June, and actually starting in June, we'll start having them monthly versus every other month, since that is when our PEDS residents will start. So be on the lookout for our next invitation. Again, thank you so much, Dr. Holmen.
Thank you.